Hello everyone and welcome to our March event. I'll just give it a moment just so that people can join and then we can welcome our speakers. So there we go, I think we've got everyone. So welcome everyone, it's lovely to see you again. We have three great speakers today for our March event. Covering the topics of dysphagia and aphasia, so a bit of an adult focus for this week. So first up, we've got Lindsey Collins, who is looking at supporting people with dementia and dysphagia in care homes. So Lindsey, let's see how these slides work.
Thank you.
Okay, so welcome.
Thanks. Are you going to give me permission to move the slide down? I've not got permission yet.
Okay, it might just be taking a little bit of time to reconnect.
Okay, yeah, so that's working. Excellent, lovely, thank you so much. So yes, I'm Lindsey. I study at university and I'm also a speech and language therapist. So today I wanted to talk to you about the findings from my PhD that I completed at the end of last year. And I was looking at the experiences of people living with dementia and dysphagia. But today I just wanted to speak to you specifically about one of my findings, which relates to the different roles that are involved in supporting people who are living with dementia and dysphagia in care homes. Okay. So the aim of my research was to understand the eating and drinking experiences of people living with dementia and dysphagia in care homes from multiple perspectives. And those multiple perspectives, sorry, I'm just waiting for the slide to click forwards. Yeah, the control's gone, so I'm not able to click onto the next slide. So could I have the next slide, please? Thank you very much. If it's okay, I'll just ask you to click the slides forward just so that I know it's going to work. So the different perspectives then that I included within the study were those of care home residents, both with and without dementia and dysphagia, care home staff, family members, and also speech and language therapists. And I took a qualitative approach to my research. So I included interviews, focus groups, and also carried out structured observations. So it meant that I could include the perspectives of people who had dementia who weren't able to tell me about their experiences. I can have the next slide, please. Thanks. So a total of 70 individuals participated in the study. So this was made up of 20 care home residents from across 7 care homes. There were 7 family carers, 13 members of care home staff of different roles, and 31 speech and language therapists. In total, I carried out 31 interviews, 2 focus groups, which were with the speech and language therapists, and I also carried out 35 hours of structured observations using a tool called dementia care mapping. So next slide, please. Thank you. So there were 4 themes that I derived from my data, 4 kind of overarching themes, and I'm going to provide an overview of one of these themes. So this relates to the conflicting perspectives of the multiple stakeholders that were involved in supporting people living with dementia and dysphagia, and thinking about the implications of having those multiple stakeholders. Can we have the next slide, please? So this is a summary of the sub-themes related to the theme of kind of who's in charge and looking at those different perspectives. So with multiple people involved, some were internal and some external to the care home environment, there was evidence that the roles and responsibilities were not always clear. And because of that, decision-making was then not straightforward. And this particularly was in relation to the roles and responsibilities of the speech and language therapist as an external member of the care team coming into the care home setting. When disagreements occurred about things like the best guidance for a person living with dementia and dysphagia, it was evident that there was an imbalance in power, with some care home staff and relatives experiencing disempowerment, and others, so predominantly the speech therapists and kind of healthcare professionals, GPs, having a more powerful and influential position. And this meant then that there were some people following guidelines that they disagreed with because they felt disempowered to challenge them, and other people then making a choice not to provide recommendations that had been made by healthcare professionals. And there were practical challenges with ensuring that information was provided and shared with all the people who needed to know it. So primarily, again, relating to the provision of recommendations by speech and language therapists and what the rationale for these recommendations were. And this contributed to some of those disagreements that I mentioned before. So these conflicting perspectives then and approaches were in the context of balancing the benefits of knowing the person with having specialist knowledge of dysphagia. So there were lots of references to challenges of trust between the different parties involved. And as well as there being challenges with kind of having the different groups involved, it was really interesting to find that there were also really positive experiences around connecting with people through the act of eating and drinking. So we saw lots of care and affection demonstrated between care staff and the people that they were supporting. And in order to kind of talk about these sub-themes a little bit more, I'm just going to share some data with you from my interviews and focus groups and observations. So I could have the next slide, please. Thanks. So firstly, there was a lot of uncertainty, as I say, expressed about roles and responsibilities and who makes decisions relating to eating and drinking. And a family member here, Jack, said, it seems to be a mystery about who actually can make the decisions. Well, not who can make them, but how they are made, as to why something is okay for one person, but not for another. And this uncertainty was shared by care staff as well. So Nadine said in relation to where recommendations come from, she said, I'm not sure if it's the nursing team or the clinical lead manager. I'm not 100% sure on that one. I know obviously the speech and language therapist gets involved and there's people that come out and assess and they make the decisions. And then obviously all the staff get told, and then that's what we have to do. So this demonstrates that challenge of not really knowing who makes the decisions and feeling kind of powerless to challenge those recommendations. So on the next slide then, there were also then a number of communication challenges that were identified. And these were highlighted by care staff and speech and language therapists due to the speech therapist coming in for a brief period of time and speaking to perhaps just one or two members of staff, and this information then needing to be passed on to everyone involved to support that individual. So one of the speech therapists, Carol, she said, I think that's similar to my concerns, that if I'm trying to give some of those more individualized recommendations, the worry is that being misunderstood or misinterpreted, or when that's passed on from one member of staff to another, it ends up being something completely different. So that real concern about giving those detailed recommendations and whether they'd be passed on. And Jack, one of the family members, also said that there were communication challenges within the care setting itself, where his wife was being cared for. So he said communication's a problem in these establishments, terrible communication problems, because I can talk to one person about something this morning or this afternoon, and they'll go away and put it in their notes, but that doesn't filter down. So recognising those communication challenges both within the care home setting and when people are going into the care home setting from external teams. So on the next slide, please. So there were also challenges in relation to trust. So one of the speech therapists, Dora, we were talking about providing recommendations that reflected changes in daily needs. So what we referred to as kind of good day and bad day recommendations. And Dora said, I don't know them well enough, so the care staff, I don't know them well enough to know their staff teams, and I wouldn't trust them to be able to make those decisions. So whether it was a good day or a bad day for that person. And a member of care staff, Sophie, also hinted at this lack of trust, saying, I just ignore their recommendations, to be honest, and I just go with what works for the resident rather than what it says on a piece of paper. We can still say in the care plan that this is what we do, because of course it's what we do, but you need to adapt things for people. So by her saying that what it says on a piece of paper, it almost downplays the importance of the advice from the speech therapist, which she felt didn't fit with what would work for the people that she was caring for. So implying that Sophie believes that care staff know better than the experts who were called in to give advice. On the next slide then, there were lots of instances of differences of opinion and disagreement. So Susan reflected on this particular aspect of the speech therapy role and said, that's why we get the SALT team in, because you find that sometimes the families think they can still eat. So obviously we need to tell them that the professionals have been in and they're now saying that's what they have to do. So there's this real feeling that care staff sometimes got the speech therapist in so that we could take sides as to what the right course of action would be. And a speech therapist, Frankie, she was aware of this as well. And she said, I sometimes find that care staff have a good understanding of the person swallowing and they're being badgered by the family, possibly out of guilt, you know, oh, but I want them to have this, that and the other. And they then want us to go just to back them up, which again is a dubious use of our time, but sometimes it's necessary. So while the care home staff and speech therapists try to kind of work out who makes the decisions and what those decisions should be, what I found was that family members were observed to still just go about their business, really. So on the next slide, we've got an example of this. So during one of my observations, I observed this interaction between Janice and her husband. So Janice is being supported by her husband, Jack, to have a snack of a piece of cake. Jack supports Janice to eat this independently by placing it into her left hand. Pleasure is seen on Janice's face. When she closes her eyes briefly, Jack puts his hand on hers and Janice snatches her hand away and seems to tell her husband off as if she thinks he's trying to take her cake. She then eats the rest of the cake independently and appears to enjoy it. When she's finished, Jack brushes the crumbs off her top and they smile together as he says, let's hide the evidence so we don't get told off. So while Jack has been told by care staff that Janice was to have a pureed diet and not to have cake, Jack was still determined to bring in cake for her because he saw the pleasure that Janice experienced when she ate the cake and he wanted to continue to promote her independence with eating, which she couldn't do using cutlery to eat a pureed diet. So the final then theme on the next slide that I wanted to share then really relates to this example of Jack and his wife, this example of kind of positive eating and drinking experience where they shared that experience together. And there were other examples of positive experiences as well. So mealtimes and snack times continue to offer this kind of opportunity for connection. So we've got an example here about Terry, from Terry, one of the family members, saying, if we bring in a couple of treats, we'll just sit here and enjoy some quality time together. And this was with his mum. And then the eating of the treats is that common interest. It's getting harder work to have a conversation. So if we bring something in like a chocolate eclair, then that's about half the time occupied and we can talk about how much she's enjoying her treats. So that kind of shared focus with his mum there. And when we were doing the focus groups with the speech therapists, one of the speech therapists, Jerry, also recognised the pleasure that care staff can get from supporting someone with eating and drinking. So she said some staff working in care homes have actually said it's a pleasure for them. So if somebody does take an hour to eat and they get to spend this time with them, it's an activity that they understand and they can just spend time with somebody and talk about the food. And there's a lot more interaction potential for them. They like doing it and enjoy that time with a shared focus. So it was really nice to see these positive experiences through kind of nourishing a person with food and drink and engaging with the person in a meaningful way, using food and drink to connect with that person. So on the next slide then, there were a few kind of implications for practice that I wanted to just mention. So I found particularly some implications for practice and for training. So supporting people with dementia and dysphagia requires careful consideration of a range of factors, really. It's important to have clear roles and responsibilities and open channels of communication between the different people involved. But it goes further than that. Really, the different stakeholders can't simply exist alongside each other, but they need to really engage in a collaborative way. They need to take a more holistic approach to eating and drinking that draws on both that knowledge of the individual and knowledge of dysphagia. So we want to think about how we can draw on those findings to think about how those stakeholders can work together. And in terms of training for these kind of collaborative relationships to work, we felt that all parties really require skills in reflexivity and also in assertiveness to speak up when someone feels that something isn't right for an individual. And also thinking then about having strong leadership, so that people can feel empowered to share their views and opinions. So just to conclude then on the final slides here, the findings from my study highlighted that in order to support people living with dementia and dysphagia, we need to give careful consideration to important factors relating to the person themselves, the environment that they're in, and also other people involved. So on the next slide in this presentation, I've focused predominantly on the other people involved. So thinking about the family members, care home staff and speech and language therapists, as well as other health and healthcare professionals, but also thinking about the factors in how they work together and the importance of communication, of trust, and of recognising power and empowering everyone to have equal say within the relationship. So just to conclude then, I just want to acknowledge on the final slide, the University of Bradford, where I studied for my PhD, the Alzheimer's Society, who funded my fellowship, and then my supervisory team, Jan Oybody, Andrew Hart, and Paula Leslie. So thank you very much, a bit of a whistle-stop tour, and I'm more than happy to take any questions if there's time, and also to take them on the chat if that's easier as well. So thank you.
Fantastic, Lindsey. Thank you so much. That was a really interesting presentation. I think personally that idea about food and drink being an opportunity for a connection and kind of something to talk about, from my personal experience, certainly resonated. So if people have questions, you can pop them in the chat. So someone's already said it's a great presentation, really good to capture this data. I might start with one question, and then if people have questions, they can pop them in the chat and Lindsey can look at them during the rest of the session. First of all, congratulations on completing your PhD.
Thank you.
That's excellent. It seems like a massive amount of qualitative data that you managed to collect. And I was wondering from a research perspective, sort of how you would dealt with such an amount of data, and was it useful kind of having the observation as well as the interviews, etc.?
Yeah, it's a great question. Thank you, Helen. Yeah, and this was just a small kind of portion of it, because there were, say, 3 other themes that I had so much data for. So yeah, I definitely found it was helpful to include observations, because all of the participants who were living with dementia, who were included in the study, had quite significant communication and cognitive impairment, which meant that they were limited in what they were able to tell me about their experiences of eating and drinking. So by using observation, it meant that I could still include their experience within the data. But yes, it was quite challenging when I came to pull that data together, because there's different ways that you can look at it. You know, I could look by kind of stakeholder group. So, you know, I could think about the staff members versus speech and language therapists versus family members and care home residents. But I found that there was so much overlap that I had to think about different ways of kind of bringing the data together, and so bringing them together under the themes was really important, and then, you know, drawing on the different types of data to demonstrate the themes, so making sure that I was including the voices of different individuals. So it was quite a challenge. I was quite systematic. Anyone who knows me, I had a spreadsheet that was color coded, because that's how I work. So I think just being really systematic in thinking about the themes and how they relate, and the different contributions people made to them. But I definitely would recommend thinking about different methods. So they were all qualitative methods, but using multiple methods to hear from different people definitely gave a huge amount of really rich data.
Fantastic. We're going to move on to the next speaker, but there are a few questions in the chat, and someone asking about ethics, which I was thinking about as well in terms of that example about the cake and things. So please do kind of have a look at the chat, and you can answer them there. And then we're going to move on to James, who is also going to be talking about swallowing. So welcome, James. And again, if people have got kind of questions for James as well, please do put them in the chat, and we can come to them at the end of his talk. Okay, so let's see how the screen sharing works, or whether Catherine might need to move the slides for you.
Yeah, I think I'll ask for slides to be moved on for me. That'd be great. Hi everyone. My name is James Reid. I'm a speech and language therapist in NHS Forth Valley, which is in central Scotland. This presentation is about a pilot evaluation of the Swallow Training and Educational Portal, which it's usually called STEP actually for short. Next slide, please. So the background to this project is that I was carrying out some personal CPD in dysphagia last spring 2020, and I came across STEP. And when I came across it, I thought it offered the potential to be a useful resource for dysphagia education in the UK. This was based on my perceived need for more high quality educational opportunities in dysphagia, especially after graduation as a speech and language therapist, and also based on COVID forcing a catalyst for change in educational models and access routes to learning. So the Swallow Training and Educational Portal, in summary, offers a subscription-based dysphagia education and training course library with 50+ hours of material. It claims to offer affordable, engaging, high-quality, evidence-based swallowing educational courses and resources created by dysphagia experts for use at any SLT career stage. So I approached STEP and to discuss an evaluation of their training portal, which they welcomed, which was great. And then I applied for a bursary from the Scotland Dysphagia Sen to carry out a pilot and evaluation of STEP, which I was awarded. And that bursary was basically to fund participants to take the course that I was going to make up for them based on the STEP material. Next slide, please. So the pilot course was set up with last spring in 2020. It was set up with 33 participants and they recruited, and it was going to run from July to December 2020. The pilot course was a bespoke version of the main STEP program, which is offered from North America actually, which we put together with the aim of being suitable for UK SLTs. So all participants completed a pre-course online survey providing demographic and background information. 22 participants represented 9 of the 14 regional Scottish health boards. There were 3 students, 3 SLTs from the independent charity sector, and 5 SLTs from England. Participants ranged from 0 to 21 years of dysphagia experience, and they were between levels A and D on the RCSLT competency framework. Some had not achieved or not working on the competency framework, but most were. The caseloads of participants included newborn, pediatric acute, pediatric community, adult inpatient, adult rehab community, and adult learning disability. Next slide, please. So these are some comments from participants at the pre-course stage. There were lots of comments, I've just put up a few. It's been difficult in the past to access learning and accreditation in a timely, affordable, local, and consistent way. Development of web-based learning observation discussion tools seems to be the way learning is progressing, and the profession should be keeping up with this. More teaching at university would be of benefit. I think we need to get much better at moving with current research and progressing after our initial learning. It has become very acceptable in SLT to do things the same way for many years without change. We need to be better at accepting and responding to research outcomes, even if they do not support the ways that we've been previously practicing. Next slide, please. So in terms of the methods that I used, I'm really just going to mention the evaluation or outcome methods that I used because of the time available. So these were participants' pre and post-course knowledge, skills, and confidence ratings. There was lots of pre and post assessments for the duration of the course. There was a quite in-depth post-course survey for everyone that completed the majority of the course. And there was post-course interviews with 8 of the participants, which went into more detail. Actual practice change or patient outcomes were not measured. It's something that would have been great to do, but unfortunately I didn't have the capacity to do all that as part of this project, unfortunately. Next slide, please. So this table shows the modules that were available to the participants and the number of assessments and questions per module. So there were 3 modules, and they were normal swallowing, swallowing assessment, and dysphagia treatment. And for example, in the normal swallowing module, you can see that there were 5 different pre and post lesson assessments, and that totaled 75 questions at both pre and post level. And you can see how that corresponds to the two other modules, slightly less questions, because the STEP course focuses quite heavily on understanding normal swallow, which is reflected in the assessment process there. Next slide, please. So quickly moving on to the results and discussion, because there's a lot of results and discussion, which is probably the most interesting part. There's lots and lots of data in this, which I'll show some of it to you here, and give you a brief overview. There is a full kind of very in-depth evaluation report which I've written, which is available if anyone wants to contact me with my email address at the start of this, then they're very welcome to, and I can send you the evaluation report. Hopefully it's going to be sent out through different groups over the next couple of weeks, and you maybe come into your mailbox soon. So this table shows the number of assessments completed at each pre and post module level. So for example, at the normal swallow pre-course level, in the top row, there were 91 individual assessments completed across all the participants. And so you can see the numbers for across the different assessments across the 3 different modules there. The average scores for participants at each level, which I'm showing on the next slide, are based on all these assessments that were completed. So next slide, please. So this chart shows the average percentage correct scores achieved by participants at pre and post module level. So if we take the blue line, which is the normal swallowing module, as an example, you can see that at pre-course, the pre-course average score across all participants was 51% correct. And at post-course, the average score was 71% across all participants. So I suppose in old traditional grading terms, that might be a shift from low C to low A. But you can see there's quite a bit of movement there in terms of percentage increase. And you can also see a very similar trend in scores that start and end at very similar points across the 3 modules. I think these assessment scores offer quite a strong indicator that by completing STEP lessons and modules, regardless of years of experience or competency, which isn't broken down in this presentation, but you'd see in the full evaluation report, participants have gained what appears to be quite significant knowledge gain across all 3 modules. Next slide, please. So as one participant quote shows here, on seeing their own assessment results, wow, quite a striking improvement. My patients can breathe a sigh of relief. Seriously though, how as a profession are we getting away with this? Participant comments might signify in some way that we need to improve our dysphagia knowledge and skills. Next slide, please. The chart on this slide shows participant responses for the self-rating categories that I'd mentioned at the start, of knowledge, which is the bottom 3 in green, confidence and skills, with both pre and post-course levels for each category shown. So participants were able to rate themselves as none, low, moderate, high, or very high within those categories. So you probably need to look at this in your own time, because I'll be going over it relatively quickly today, but the ratings on each of the 5 indicators do show an overall increase towards the high end of the rating spectrum at post-course level, which signifies that participants feel knowledge, confidence and skills have improved. So that there's an increase in kind of the yellow bars at post-course level compared to the pre-course level, and a move up from orange to grey, which goes from low to moderate as well. So that happened across all the factors there mentioned. So, but it's also worth bearing in mind that in the post-course evaluation, over 60% of participants agreed or strongly agreed that they'd overestimated their pre-course dysphagia knowledge, which the content of the course and the assessments made them realise. So the actual difference between the pre and post ratings might actually be significantly larger because people had felt they'd overestimated their knowledge so much. Next slide, please. So participants then rated the quality of STEP based on 10 factors shown in this chart. which I'm not going to go into individually, but they rated them at either poor, adequate, good, or excellent. And the results show that 80 to 100% of participants rated every factor as either good or excellent. Many of these factors are considered critical or important to the learning experience and outcomes that STEP is aiming to achieve. Therefore, the result seems to give a reasonable degree of confidence that STEP is able to provide a high quality learning experience for SLTs. Okay, we'll move on to the next slide, please. Yeah, there's another big chart, which you might want to take some time afterwards to have a look at. But I asked participants more questions afterwards in the post-course survey, so that they were rating their personal development and a range of other quality indicators following their STEP experience by agreeing or disagreeing with 11 statements, such as I like the promotion of critical thinking over recipe book approach, or I enjoyed the course, or STEP offers learning material that is not mirrored elsewhere. There's lots of questions were asked here. So except for overestimation of pre-course knowledge, 80 to 100% of participants rated every factor as either agree or strongly agree, as you can see from the yellow or dark blue bars. So these ratings kind of correlate with what is considered a positive change or outcome or a positive aspect of the course, which again suggests that STEP can offer a highly valuable learning experience. Next slide, please. So in the post-course evaluation and in the post-course interviews, there was an awful lot of comments from very useful and interesting and insightful comments from participants. And I carried out a thematic analysis on lots of all of this information, and there's just so much information that could be gone through that I don't have time to go through it with you today. So you can see all that in the full evaluation report, and it really brings home what people thought about it. But one of the things that I'm not really discussing in the presentation today is how people feel about the current state of dysphagia education and practice across the UK. So there was lots of interesting and insightful comments from people about how they felt that situation was and how it could be improved potentially in the future. Next slide, please. So in conclusion, I felt that the online model for swallowing and dysphagia education that STEP delivers is certainly timely at the moment, and it's facilitated significant knowledge gain for participants who took the course, and it seems to have been very well received by most participants of this evaluation. It's proved successful for qualified and unqualified SLTs, and may act as a catalyst for change in some areas of dysphagia teaching and practice. So that's the end of my presentation. Thanks for listening, everybody. I'm happy to take any questions about that.
Thanks so much, James, and thanks. That's great to hear the full evaluation report is available. I'm sure people will be in contact, and that good to hear that it'll be sort of spread more widely for some more detail. So if anyone's got any questions for James, please do pop them in the chat. I would certainly think it's timely, both in terms of kind of COVID and the move to online, but also in terms of the pre-registration dysphagia competencies, in terms of kind of shifting this into sort of university teaching. That I think there's probably quite a lot of learning from your project, which is excellent. I'll see if anyone has questions in the chat. So my question was, was there anything surprising to you in the findings? Was there anything you were sort of not expecting?
I think the finding that no matter what the level of experience or level of competency that the practitioner had, there was quite a broad across the assessments in particular, and even from their follow-up responses, was that there wasn't a huge the people who were more qualified and more experienced didn't necessarily score any better at the start in pre-course assessments. I wasn't actually setting out to find that out. It was more just to see whether there was a change between pre and post course, and what that change would be. But it was interesting to see that even between less qualified and more qualified people, there's still a certain degree of dysphagia knowledge and potentially skills that we might be we might not have, and maybe that's something we need to consider as a profession about what we do know and what practices we have in place at the moment, and whether we should make any changes to that or act on trying to make changes to it.
Yeah, I think it certainly highlights that point of kind of the need for ongoing CPD, and that we're sort of always learning, even though, we might have sort of done formal courses, that there's still always scope. A question here from one of the attendees was saying it's interesting that connection to the data competencies was one of the worst rated. So do you think this is because it only covers some competencies, or just difficult to map to the competencies that could be done, or 3 other? So why do you think basically that was the worst rated?
Yeah, I don't think it was the worst rated, but it wasn't badly rated, if I could say that, because most others were really well rated, so it appears that that's the worst one, but that's well spotted by the listener. So there was no mapping done to the competency framework prior to people taking this course. So a lot of people commented, and I had that view myself, that a good exercise to do would be to map the STEP learning outcomes and content onto the RCSLT competencies, so people knew that what was the content of each lesson, how that mapped onto the competencies. And the other thing is that it doesn't cover every aspect of it doesn't cover every aspect of the competencies, that's for sure. It's not teaching people skills, it's it's primarily knowledge that you're gaining here, and you need to go away and put things into practice and practice skills. So it's not at the moment, STEP doesn't offer you everything that you would need to achieve in a competency. You need to find other ways to learn things, or you need to put skills into practice to achieve certain competencies. So I think that's why people rated it as less, not as good.
Yeah, fantastic, great, thank you. There's another comment there, just someone was saying as well about they had thought about subscribing to STEP, but were on the fence, so it's quite nice to hear sort of the inside knowledge of it.
Can I just add that?
Yeah, sure.
So if STEP is a North American produced dysphagia education resource, so that was I was wondering how that would go down. So we did change it a lot we changed it a bit to make it more UK friendly and relevant, and we're hoping to work further with STEP now to release an updated UK version of STEP, which is based on lots of participant comments about how it could be improved to meet the needs of UK speech and language therapists even more. So if the participant is listening, wants to hold on a bit, they might find that the release of an updated UK version that they can access if they want to.
Yeah, I think that's really interesting, and I think it'd be really interesting to see those comments about maybe what needs modifying. Some, again, from own experience of sort of some of the American resources. So fantastic, thank you so much. So you can, James, you can see those comments in the chat now, and if anyone else has anything, questions to ask James or any comments, please do pop them in the chat. But for now, we're going to move on to Nicky, who, and we're going to be shifting from thinking about swallowing to thinking about aphasia. So welcome, Nicky. Thanks very much for joining us, and off you go.
Thanks so much, Helen, and I'm happy for you to move on to the next slide when I ask you, if that's okay, just to avoid any technological breakdown. So my little presentation here is on mood screens in aphasia, and as we know, patients who have stroke are at high risk of low mood, and patients who have communication difficulties following stroke are at especially high risk of low mood. And I guess at some level I've always been conscious of that and try to work it into my practice. But it really came to the surface after I attended an aphasia rehab conference a couple of years ago now in London, and I saw Madeline Cruz talk about low mood in aphasia and general well-being for our aphasic patients. And I wanted to bring it back and do something really practical at a local level. But as we know, with a full caseload demands, things happen slowly and you have to kind of fit it into your working practice. So it has been a little while in the making. But I decided to try an audit. I hadn't completed one before. And this audit was a prospective audit recording over a period of 3 months whether a mood screen is being completed for patients, our patients with aphasia, what the general mood screens are, and then comparing those as you would do in audit to established standards. And I also wanted a qualitative arm really to look at the SLTs within the adult speech therapy team, to see how they felt about mood screens and to see whether they were confident in delivering mood screens. Okay, so next slide. So here are the standards. Apologies if they're a little bit small. We looked at 4 main standards, 2 were national standards and 2 were more local standards. So the first national standard came from the clinical guidelines for stroke, which state, if possible, assessment measures should be adapted for the use with people with mild aphasia, and that specially designed mood screens should be used with those who have more severe aphasia. And they give a few examples here, so the SAD-Q, the DISCs, and the BOA. So the second standard comes from the NHS Improvement for Stroke Group, who state that assessment of mood using standardized measure and interview should take place routinely on at least 3 occasions. So 1 month post-stroke, 3 months post-stroke, and then 6 months post-stroke. And then going into the local standards, so the first local standard was from our Stroke Rehabilitation Unit, or SRU, and their standard involved completion of a mood screen within the 5th and 15th day after the patient was admitted to the unit. And then the last and 4th standard was from the early supported discharge team. So it's the team that I work in. And that standard states that completion of a mood screen, if one has not been should happen if one has not been previously administered, or if there's a reason to think that the patient's mood has deteriorated. So it was actually more difficult than I thought to find some standards, especially linked to aphasia, but those were the 4 that we chose. So next slide, please, Helen. Lovely. So let's have a look at the first standard, and I split that into part A and part B. And part A looked at whether assessment measures were being adapted for patients with mild aphasia. And I'll just talk you through the teams that we were looking at this for the entire audit, actually. So as I've mentioned before, we've got the early supported discharge team, we've got the stroke rehabilitation unit, we've got PLIM, which is a neuro rehabilitation unit, and then we've got the adult community speech therapy team. And you can see for this standard that ESD were actually the only team that was adapting mood screens for patients with mild aphasia. Next slide, please. Okay, and looking at the second part of number 1, so the part what that states that mood screens specifically designed for people with more severe aphasia should be used. And you can see that ESD and the stroke rehab unit were using those specifically designed measures 100% of the time. Although, I mean, you can see the numbers, our numbers are quite small, so, so do bear that in mind. Next slide. Okay, so for item 2, looking at those time frame specific points that we should be doing the mood screens within, you can see that ESD and the stroke unit were partially meeting that standard, but not to a great extent. And I guess it should be considered that that generally these 3, apart from the community team, probably would not be seeing patients 6 months post-stroke. So that does affect the outcome and results for this standard. Okay, on to the next slide, please. Okay, and so this was the stroke rehab unit specific standard, and you can see that they were meeting their standard 100% of the time. And next slide. And so for the ESD specific standard, you can see that that we were meeting the standard 84% of the time, and that was generally because sometimes patients can be discharged quite quickly from the team, and it might not always be the case that we'd get chance to complete a mood screen. We have quite a quick flow through. But those patients who didn't have the mood screen, that certainly wouldn't happen for patients who had demonstrated a deterioration in mood. They would have always had that mood screen completed. Okay, next slide. So the qualitative branch of the audit, like I said, it looks around general feelings and attitudes towards the mood screens that we're completing with our aphasic patients. And you can see from this table here that the general consensus is that people feel quite unconfident in terms of adapting those mood screens for people with aphasia. And we had the standard that said you should be doing that with our patients with mild aphasia. But yeah, so you've got 38% of there quite unconfident. Next slide. And so you can see that there's a bit of a theme here, and there's a general feeling of underconfidence in terms of identifying which mood screen is actually appropriate for each patient. Next slide. So in terms of how confident people feel in taking appropriate action following the mood screen, yeah, that is quite a high level of underconfidence. And I think one SLT on PLIM noted that actually they have access to neuropsychology, so they would be the people that would be carrying out, low to moderate mood sort of interventions. Next slide. And have you had training whilst working for LiveWell? LiveWell is the social enterprise that we work for, and it delivers speech therapy for the non-acute patients, so all the rehab patients basically. And you can see that there's quite a large proportion who haven't had training. And one person notes that they've registered for as many mood-related training options offered by LiveWell, but they're not delivered routinely. So I think there is a demand. There's a demand for training, but not necessarily the access to training. And next slide, please. Okay, so let's look at the general conclusions drawn from this audit. We can see that there is some good practice within the speech therapy team. The stroke rehab unit and ESD are administering some kind of mood screen. And we're consistently using specifically designed mood screens for those patients with severe aphasia. Next slide. But there are definitely some areas for improvement. And I think that's part of the reason why you do an audit, isn't it? You can kind of identify that something's not quite right, or you suspect that something's not quite right. And an audit is an amazing tool for identifying the specifics and actually helping you to develop practical outcomes. And we could see that as an SLT team, we're not routinely carrying out mood screens with those specific timeframes. And there were no mood screens being carried out by the community team or the speech therapists on PLIM, the neuro rehab unit. Okay, next slide. So limitations. I kind of thought that a 3-month prospective audit would sort of provide us with enough data, but it's a really small sample size, and especially when you look at PLIM, they have head injury patients and spinal patients, so actually they don't necessarily get a high throughput of aphasic patients, so that sample size was quite small. We did query maybe are all the standards that we compared ourselves to relevant for our areas? Do we need a mood pathway, or do we need to develop more of our own local standards? And there were a really low proportion of patients with mild aphasia, so it's difficult to see whether we were truly doing all the adapting that we could be. Next slide. So our action plan, so myself and a few other SLTs across the different areas, plus a couple of psychologists and psychiatric nurses within LiveWell, have formed a working party looking to sort of work through the issues that we think that we have and the things that the audit threw up. And so the first task, the first thing that we've been doing is adapting some mood screens already for those people with aphasia. And we've looked at adapting the PHQ-9, which is the Patient Health Questionnaire, and the GADS, which is the General Anxiety Disorder Questionnaire. And we looked at those two specifically because they're what GPs down here tend to use. They're also what other people, sorry, my computer's trying to restart itself, so I have to stop that. It's generally what the inpatient therapists are using in terms of mood screens. We thought, as the speech therapists find adapting mood screens quite difficult, if we have pre-adapted mood screens that they could just pick off the shelf, then that would be providing some sort of improvement in efficiency and maybe take up of mood screens with our patients. So we split that into, we've got kind of two different sections for each of those mood screens. We've developed a talking maps version of them. And we've also developed, I don't know if any of you are familiar with the Coast, but kind of a Coast similar sort of layout where you've got a picture of something at the top, and then you've got a few words or a short phrase, and then you've got a yes option, a no option, and a sometimes option. So we've done that, and we're in the process of trialing it across LiveWell. And if it's successful, well, no doubt it will need a few tweaks, but if it's successful, then we'll roll it out. And maybe, I mean, it would just be good to make it available to all speech therapists. You know, if we can make life easier, then that would be amazing, wouldn't it? So hopefully you'll all see that coming out at some point. We're then looking at developing agreement of local standards around mood screens, potentially a mood screen pathway or algorithm, and a review of training provision and liaison with psychology. Our psychology team are brilliant, and they're quite proactive and keen to deliver training. So I think that would be great. And then obviously we'll look to re-audit. But I think in conclusion, I'm very pro-audit now. I think it's a really good way of identifying an issue and actually helping that to develop into practical steps of you know, improving service. So thank you, and any questions?
That's great, Nicky. Thank you so much. Really nice to sort of talk through the process of audit and yeah, and see the benefits, but especially if it's something that you're thinking, oh, maybe we're not quite doing this, that you can sort of perceive that audit might be a negative thing, but actually you've used it as really positive. And just a really nice example of sort of some of the challenges of practice-based research in terms of kind of limited numbers and but still able to get a lot from it. So yeah, that was great. So we've got a question from Catherine. Say, I love that this audit was inspired by research. Do you have any idea of whether SLTs know how to respond to people who score poorly on mood screens, i.e. who have a need for support with their mood? And I guess this feeds into a what next question too. So are you planning on re-auditing, which you are, and would this future audit include any data about mood interventions?
Yeah, I think that's the natural, it's going to be the natural flow really, isn't it? You know, let's get a bit more confident in assessing, but we all know that when you do a mood screen with a patient, you're potentially opening a Pandora's box, and we need to feel equipped as SLTs to provide appropriate intervention or signpost or seek help where necessary. So I'm hoping that it will also develop into a greater level of training. And I know as speech therapists, we're supposed to be able to deliver low-level intervention in the stepped care model. And and I don't think we do feel confident at the moment, and I don't think there is enough training out there. So yeah, I'm confident that it will flow through to more practical measures being used.
It's often the thing that sometimes you ask these questions and then they generate more questions, don't they?
Yeah.
But certainly that kind of MDT aspect, and that actually the working party is multidisciplinary and drawing people in is fantastic.
It's really brilliant, and I think psychology is so naturally aligned with speech therapy, but they also work in a different way, and they're I think they do a lot more research, don't they, within their practice. So it's been really helpful, and actually, you know, yeah, really helpful for the audit and the psychology assistants helping me out with, you know, tables and things. Yeah, brilliant.
Yeah, certainly a good idea to make use of anyone that's got good skills in those areas. And then also Sally has added that it might be nice to tell Madeline Cruz that she inspired this work, because academics are always love to, get some positive feedback. So.
Absolutely, that's a very good point, and I will drop her an email and let her know what's happening.
Yeah, great. We've got a few minutes. If anyone's got any other questions for Nicky, you can pop them into the chat. And again, Nicky's contact details are on there, and I'm sure she'd love to hear from anyone interested in this area or working in that field. And just to say, we're going to take a break for April for the next seminars, just the way in terms of it's worked out with speakers, but also that we might have some sort of more freedoms, and it falls in the Easter break, so people can have some time off. So we'll be back in May, and we've got some great speakers lined up for there. And we have one slot still in May, so if anyone is inspired and would like to present about anything that you're working on, ideas for things that you would like to do, kind of just to get some feedback, please do get in contact with myself or Catherine, and we can put you in. Certainly very happy to hear from potential speakers. Otherwise, it was lovely to see everyone, and have a nice rest of your afternoon. These sessions have been recorded, so they will go up on the RCSLT YouTube channel in time, so you can kind of catch up then, and please do direct other people to them. Okay, lovely to see everyone today.